Slides are seen, but presentation mode.
Yeah. Not able to do that.
Sir, you stop sharing, and
Yeah.
then share the entire screen. Stop this sharing. The reshare, sir. Stop share. Then share entire screen. Click on that slide sharing, share screen icon.
Entire screen. Okay.
Then share entire screen and then click on minimized PPT. Share entire screen. Share entire screen, sir. Yes. Now click on the PPT, which is minimized on your desktop. Click on that PPT. Yes. And now you can do presentation. Now you do slideshows.
Yeah. You're able to see now?
Yes.
So good evening, everybody. At the outset, I'll be speaking on new frontiers in diagnosis and monitoring of type 2 diabetes. Special focus on CGM, that is continuous glucose monitoring. So if you take the diagnosis criteria of diabetes from ADA, you can see A1C more than 6.5. The test should be performed in a laboratory using a method which is certified and standardized. Next, fasting plasma glucose more than 126. The fasting is defined as a no calorie intake for at least 8 hours. Next is the 2 hours postprandial glucose, that is more than 200 during the oral glucose tolerance test. The test should be performed as described by the WHO using a glucose load containing the equivalent of 75 grams of anhydrous glucose dissolved in water. Or in an individual with the classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose of more than 200. Random is any time of the day without regard to the time since previous meal. This is all is a very basic things which we all know about it, but to refresh ourselves. So if you take the HbA1c, it's a long-term glycemic marker. The advantages is it predicts the risk of complication, useful for preventing both short and long-term diabetes-related complication. No need to fast, can be done regardless of the meal timing. Stable and reliable, offers strong analytical and pre-analytical stability. Long-term glucose measure that reflects average blood glucose over the past 2 to 3 months. More efficient with CGM. HbA1c plus continuous glucose monitoring provides a more complete picture. But there are red flags for HbA1c. Any condition that prolongs the life of the erythrocyte or is associated with decreased red cell turnover exposes the cell to glucose for a longer period, resulting in higher HbA1c level. So it is clinically significant discordance between A1C and SMBG and CGM trends. Rapid glycemic fluctuation not captured due to delayed A1C responsiveness. Underlying conditions like anemia, renal failure, recent blood loss and transfusion can vary the HbA1c level. Use a clinical correlation approach. Don't rely on A1C in isolation, which is very, very important. So in this slide, it shows the non-glycemic factors affecting the HbA1c levels. See, there are, on the left-hand side, you can see the red blood cell turnover, like it is high, example, cystic fibrosis, hemolysis, or hemorrhage with subsequent transfusion may falsely lower the A1c. If we low, example, iron deficiency, anemia, and spirocytosis may falsely rise A1c level. So there are certain drugs which interferes like dapsone, ribavirin, antiretroviral, trimethoprim and sulfamethoxazole, hydroxyurea, vitamin C and E, and aspirin may falsely lower HbA1c through different mechanisms. Large doses of aspirin or chronic use of opiate may interfere with the assay and rise HbA1c level. So there are another important factor is the hemoglobin variants or elevated HbF. This interferences with the certain assay. And the most important thing is ethnicity and race. Higher HbA1c level among the US racial and ethnic minority groups like African Americans, Hispanics, American Indians, and Asians. Next point is the renal function. The carbamylated hemoglobin may interfere. Some degree of caution is needed when interpreting HbA1c measurement results in patients with impaired renal function. Age, HbA1c levels increase with age may be due to different rate of glycations. So these are the major things we should consider. And on the right hand side, you can see the causes, various causes which causes elevates HbA1c. There are iron deficiency, anemia, chronic kidney disease, vitamin B12 deficiency, severe hypertriglyceridemia, aging, black race, Asian race, Hispanic ethnicity, hemoglobinopathies, genetic factors. There are certain conditions which reduces the HbA1c like a pregnancy, hemolytic anemia, erythropoietic therapy, iron and B12 deficiencies or replacement, chronic liver disease, antiretrovirals, hemoglobinopathy, and genetic factors. So the disadvantage of HbA1c, it's a delayed feedback. It cannot reflect the short-term changes, not ideal for quick medication adjustment. It misses daily variability. It does not capture glucose fluctuation, hypo and hyperglycemia episode. It is affected by RBC conditions like unreliable in patients with hemoglobinopathies, anemia, or thalassemias. And most important in our country, the standardization issue, the lack of NGSP certified labs limits result reliability and comparability. Last but not the least, the cost burden. Testing costs around 250 to 450 tests in India. Next aspect is fasting plasma glucose. It's a practical tool. It is useful in predicting future diabetes. This is an important aspect. Children with fasting plasma glucose of 86 to 99 have twofold risk of adult diabetes compared with fasting plasma glucose of less than 86 milligram, as shown in Bogalusa heart study. Next point, FPG and early beta cell dysfunction. Even FPG within the normal range may signal 23% decline in beta cell function, 49% decline in impaired fasting range. So these effects are independent of obesity and race. So the oral glucose tolerance test is the gold standard tool. It reveals postprandial glucose handling, detecting early beta cell function and insulin resistance. It is more sensitive than FPG or HbA1c in diagnosis, like impaired for glucose tolerance, gestational diabetes, early type 2 diabetes. So the 2-hour post-load glucose strongly correlates with beta cell functional capacity. It is not validated extensively in pediatric population. So the OGT indication and factors affecting the interpretation. You can see on the left-hand side, there are various indications for OGT, like age more than 45 years, body mass index of more than 27, high-risk ethnic groups like Africans, Caribbeans, and Asians, family history, that is first-degree relatives. If they have got diabetes, it has to be screened. High waist circumference, more than 92 centimeter in males and more than 80 centimeters in female. Sedentary lifestyle, history of gestational diabetes, previous evidence of IGT or IFG, dyslipidemia, that is decreased HDL and increased triglyceride. This is typical of Asian people, and patients with cardiovascular disease. Women with polycystic ovarian disease, women who delivered a macrosemic baby, have other clinical condition associated with insulin resistance, hypertension, recurrent infection. So in all these conditions, the OGTT can be performed to see the how the diabetic status is there. Next, what are the advantages of OGTT, that is oral glucose tolerance test? It detects glucose intolerance before fasting hyperglycemia appears, essentially for identifying IGT, which increases the risk of type 2 diabetes and cardiovascular disease. More accurate diagnosis, A1C more than 6.5 identifies 30 to 40%, FPG more than 126, 46%. Now look, 2-hour OGDT is 90%. So it is crucial in diabetes prevention trial, metabolic syndrome workup, and insulin resistance evaluation. So what are the limitations of OGTT? Time consuming, expensive, unpleasant, because of some patient may have nausea and vomiting, not suitable as a mass screening tool. Single OGTT may overestimate diabetes prevalence by 16%. It needs repeat testing to confirm diagnosis unless grossly abnormal. So this slide summarizes what I have discussed till now. That is the fasting plasma glucose, OGTT, and HbA1c. So, if you take the diagnostic confirmation, in the absence of hyperglycemic symptoms, two abnormal results from the same or different test, like fasting plasma glucose, 2 hours post glucose A1C level. If discordant, repeat the abnormal testing, consider interfering factors. Borderline results educates patients on the symptoms and lifestyle, re-evaluate in 3 to 6 months with full clinical context. So HbA1c only provides a 90-day average. You can see three different patients, patient A, patient B, and patient C, how the differences will be there. On the left-hand side, you can see patient A, HbA1c, if it is 7, 100% they may be in range. That is one type of patient. In the middle, patient B, even the HbA1c shows 7, but in range, you can see 63%, 8% hypoglycemia, 29% hyperglycemia. That is HbA1c less than 7. See the difference compared to patient A and patient AB, how the differences are there. Here only 63% is in range. Rest is in abnormal, nearly 27% is abnormal, which may not be highlighted. We think HbA1c is normal, but the actual fact is this. Next, on the right hand side, you can see the patient C, where once again the HbA1c is 7, where 58% will have hyperglycemia, 24% hypoglycemia, and 18% in range. Only 18% in range. But HbA1c is 7. So we what practically feel, oh, the patient's sugar control is very well. But actually, in fact, the patient is having a very bad glycemic variability. So severe hypoglycemia is common among patients with diabetes across all levels of glycemic control. So A1C does not track glycemic excursion. 60% of the glucose lows may not be revealed with SMBG alone. CGM identified 4 times more serious glucose excursion than SMBG. So therefore, every patient should undergo CGMS given a chance. So there are certain alternative glycemic markers like fructosamine and glycolated albumin. It reflects glycemia over 2 to 3 weeks, useful in settings of altered RBC turnover or recent glycemic shifts. Continuous glucose monitoring recommended for select clinical scenario, that is mismatch between A1C and glucose metrics, not currently validated for initial diagnosis of diabetes or pre-diabetes. So the glycemic assessment by serum glycated protein assays, the fructosamine and glycated albumin are approved for monitoring glycemic status. Like fructosamine is a total glycated serum proteins, mainly albumin. Glycated albumin is proportion of albumin that is glycated. It's highly correlated with each other and show excellent assay performance associated with long-term complications in cohort studies, limited clinical trial data compared to HbA1c, useful when HbA1c is unreliable or unmeasurable. So continuous glucose monitoring system, that is CGMS. It is a device that records glucose level throughout the day and night. It can provide up to 288 glucose measurements every 24 hours. The system is used to measure an average blood glucose for up to 6 days, while the person with diabetes continues daily activities at home, at work, at home and activities at home at work. So bottom, you can see the typical CGM, how it looks. Starting from the left-hand side, if you go see the graph, the alertness, so the range, you can see the middle part where it is the dotted lines is there. That is the range. For example, you take bottom is 70, higher range is 180. That is the range. We want that patient's range to be between falls between these two values, that is 70 and 180. So on the left hand side, you can see when the patient's sugars are going down, there is an alert warns patients of ongoing hypoglycemia. Next, you can see the bottom when it goes below the dotted line, which you are able to see. I'm showing in the arrow mark. The prompt action required to avoid hypoglycemia or reduces its duration. Then you can see there is a good level in time in range here. Then once again, there is an alert warns patients of ongoing hyperglycemia. That tells the patient is crossing 180 or 200, whichever you want to fix. So the prompt action required to avoid hyperglycemia or reduce its duration. So high glucose threshold and low glucose alert threshold, we can fix according to the patient's need, age, associated medical condition. So this is very important. We maintain the sugar level in the target zone. This is where the CGM plays an important role. So CGMs continually monitor the blood glucose, giving real-time updates through a device that is attached to the body. Insulin administration and blood glucose monitoring have transformed from multiple finger pricks in a day to a few swipes on the cell phone. CGM measures glucose level in the interstitial fluid. So the CGM compromises the three following parts: a sensor that measures interstitial glucose level, a receiver or monitor that displays data, a transmitter that enables the communication between the other components. You can see in this part of the slide, which depicts, so from the bottom you can go, the blood capillary we know, next is the glucose, next is the skin, that is the subcutaneous fat tissue. Blood capillary, subcutaneous fatty tissue, and skin. So these are the, see, you can see the CGM sensor, that is small plastic one which will be beneath the skin. Then you can see the CGM transmitter here and the receiver. So these are the three parameters. This is a very simple one, usually put in the back side of the upper arm. So that is the recommended place. It can be put on stomach also, but the recommended place is back side of the upper arm. So that is the most accurate position and very comfortable to the patient. It is usually waterproof. They can do swimming, bathing, everything. So the quality is very, very good given by a good company. So the glycemic assessment by CGM. So CGM is valuable for individuals at risk of hypoglycemia, especially those with type 1 diabetes, growing use in type 2 diabetes on insulin as well as in GDM as well. So key metric, that is time in range, you have to maintain, that is TIR. Time in range is TIR to be maintained around 70 to 180 milligram per decile. Target more than 70% or TIR around A1C approximately 7%. This is how the correlation is there. Short CGM duration, that is 10 to 14 days with more than 70% wear time, is effective for assessment. The other CGM metrics, that is time below range less than 70 and less than 54, time above range more than 180, mean glucose, glycemic variability, and glucose management indicator. So the ambulatory glucose profile, that is visual report, helps guide treatment decision. If you take a overview, it's a minimally invasive technique measuring glucose level in interstitial fluid using a subcutaneous sensor. Data capture, it records glucose every 1 to 5 minutes for 7 to 14 days, depending on the device. There are different types of CGM devices. By function, if you take the first one is the real-time CGM, continuous reading plus alarms for hypo and hyperglycemia. That is the best part. If the patient is going for hypo or hyper, there is an alarm. Next one is the intermittently scanned CGM. It requires scanning at least every 8 hours. By usage, if you take, there is a personal CGM. The data visible to patients helps in insulin adjustment and lifestyle tracking. Next is the professional CGM. Data hidden from patient used retrospectively by HCPs for treatment planning. So in US FDA approved CGM devices way back in 2013, that is 12 years ago, approved a sensor augmented insulin pump system with automated low glucose suspended safety features, that is Medtronic's Mini Med 530 with Enlight for use of 16 years and older with type 1 diabetes. When the continuous glucose sensor detects that blood sugar has fallen below 62 and 90, and the patient fails to respond to first alarm, the pump automatically stops insulin delivery. This is insulin pump, what is there, where the CGM also plays an important role. In 2016, Dexcom G5 mobile CGM system replacement for finger stick testing for determination of insulin doses, although twice daily finger stick testing was still required for calibration. In 2018, Medtronic standalone CGM, Guardian Connect, which eschews use of receiver and makes a data viewable via smartphone display alone. In 2017, Freestyle Libre flash glucose monitoring system, that is about diabetes care, allows patients to reduce the number of required finger sticks by measuring glucose level via a self-applied sensor inserted into the back of the upper arm. In 2018, Eversense continuous glucose monitoring system, the first CGM system with a fully implanted glucose sensor for person aged 18 years or older with diabetes. Using a fluorescence-based sensor that physicians implant subcutaneous in the upper arm, the device has transmitter that is worn above the sensor. In addition, the app alerts the patients to high and low glucose level, with the transmitters also emitting on body vibration alerts. So the device is intended for adjunctive use with finger stick monitoring, and twice daily calibration is required. The implant lasts for up to 3 months before needing replacement. The FDA approved professional CGM system in 2023, that is 2 years back. Left hand side, you can see that iPro 2. In the middle, Freestyle Libre Pro, that is 14 days blinded only, fully disposable. Next, on the extreme right, you can see the G6 Pro. The advantages of CGM: it detects the glycemic variability, postprandial spikes, dawn phenomena, and Somogyi effect, identifies asymptomatic and nocturnal hypoglycemia, aids in understanding the impact of lifestyle and diet, enhances insulin therapy effectiveness in both type 1 diabetes and insulin treated type 2 diabetes, supports better medication adherence through visual feedback. This is from our own RSSDI, where I am the executive committee member. So this is the recommendation done and published in International Journal of Clinical Metabolism and Diabetes this year. Ambulatory glucose profile. See, this is how looks a busy slide, but very simple to understand. You can see on the left-hand side the glucose statistics. For example, they are taken for 14 days here, or 13 days you can take, 26 February 2019 to 10 for March 2019. You can see the percentage time CGM is active is 99.9%, because it is continuous process. So the average glucose, what they noticed was 173, glucose management indicator was 7.6, glucose variability of 49.5%. Left hand bottom, you can see the most important thing to consider is the green part. That is the target range. That is 70 to 180. Here that is 47%. And 23% what you are seeing in the yellow is high, means above the target. And you can see very high, that is above 250, nearly 20%. The most important thing to be seen also in the bottom means patient has gone for low, that is less than 70, that 4% are gone, and very low, less than 54 milligram per deciliter, it was 6%. So this is the advantage of CGM, where you can see the ambulatory glucose profile report, which shows what is the time the patient is having target range, high glycemia or very high glycemia or hypoglycemia or very low hypoglycemia. On the right hand side, you can see the top one where the blue range, blue things are there. The main thing you have to keep is this target range, that is 70 to 180, where I'm showing in the arrow 70 to 180. So this is above range. You can see at 9 a.m. this person is having hyperglycemia. At the same time, you can see here at the midnight, 12 a.m. to 3 a.m., the patient is going for hypoglycemia. So this helps to identify the reason, monitoring the sugar level, adjusting the dosage of medication, educating the patient about the various food. For example, if a person has taken biryani, it spikes, it shows, see, this is what it is happening in your body. If you are taking a good protein-rich diet, you can see, this is how your sugar is maintained in time in range. So the patient really understands by seeing these graphs, and it will be very easy to educate and make the patient aware of this glucose levels in the body. So where is the problem? You can see, as I discussed, high glycemia is seen, hypoglycemia is seen. So this is where we can educate. The red one is hypoglycemia, the red circle. The yellow one is the hyperglycemia, and very high sugar levels also can be detected. So this is where we can say and reduce the medication or increase the medication depending upon the levels. You can see in this graph, it shows the 14 days graph here. So you can see Wednesday at hypoglycemia, Saturday at hypoglycemia in the early morning, and in the evening it has got hyperglycemia. Maybe weekend the patient would have partied somewhere, so you can see the high sugar level there. So once again, Monday, you can see by 12 p.m. onwards, the sugar is level is here. So we can tell what did you eat, what are the food pattern you are having, what is the diet you are following. So your sugar level are increasing. You can tell based upon that levels. So this is 14 days graph. At the end of 14 days, you can sit with the patient, discuss. If the patient makes a chart of what they eat, what they ate, also helps us in educating the patient. So one is raising doubts, another is demystifying. This is a very important statement. On the left hand side, you can see the blood glucose motor, that is meters, still leaves the question. For example, I am at 160 milligram per deciliter. Am I going up or down? The answer is no. They don't have an answer. At the bottom, you can see I am at 160. I am going to up and down. The question remains the same. On the right hand side, you can see with the CGM how it answers the question. I am at 160. Am I going down? My glucose is going down fast at the rate of 1 to 2 milligram per deciliter per minute. So the CGMS can provide the answer and a more complete picture to allow the patient to make the best decision about their diabetes management. So you can see a comparison between self-monitoring blood glucose versus CGM. On the left-hand side is the self-monitoring glucose. It only gives number of fasting plasma glucose, postprandial glucose. It doesn't give the full day glucose strength. This is the SMBG. On the right-hand side, you can see CGM with complete picture of blood glucose strengths. It takes reading every 5 minutes, which is 288 readings in a day. So the SMAG provides real-time feedback, but the problem is when measurements are taken infrequently, we don't know what happens in between. So continuing that, you can see the HbA1c versus CGM. What is the difference between HbA1c and CGM? So HbA1c tests average of last 3 months blood glucose number only and doesn't unveil any type of trend. On the right hand side, you can see the CGM provides complete information of blood glucose level, hyper, hypo, and meal-induced changes. The most important aspect of CGM is the time in range, which is a key CGM metric. So definition, you can see TIR is the percentage of time glucose levels stay within the target range, a modern dynamic marker of glycemic control in type 1 and type 2 diabetes. A standard target range, general adults, we usually keep it at 70 to 180 milligram per deciliter. For pregnancy, maybe still tighter, 63 to 140 milligram per deciliter. So the TIR goals, what we want, 70% per day for most adults, that is approximately 16 hours a day, more than 50% for older adults or high risk patients. What is the clinical significance of TIR? So higher the TIR is associated with lower HbA1c and reduced risk of microvascular complication. Means higher TIR means higher time in range, means higher, that is more than 70%. If the maintenance is good, the HbA1c will be well under control. In the long run, we have so many studies which shows it reduces the microvascular complication. The next point, TIR complements A1C by identifying daily fluctuations and treatment response. TAR, this is time above range, and TBR is a time below range, helps assess treatment efficacy and hypoglycemia risk. So the treatment focus, increase TIR and minimize TBR to improve glycemic control and reduce complication. So the key benefits of CGM in all types of diabetes: significant reduction in mean HbA1c, decrease in time spent in hyperglycemia, healthier lifestyle, improvements in metabolic outcomes, increase in time in range. The future of CGM systems, if you take, it is growing adaptation is there, historical contest like GlucoWatch and SugarBeat is there. Current challenges, what we are seeing is the non-invasive sample testing, technological advances where we have Eversense, that is fully implantable CGM system with NFC technology. Next is the license. Next is the integration with the wearable tech, that is combining CGM with physical activity and physiological monitoring for improved control. And the sustainability focus, the Green Diabetes Initiative promote as eco-friendly practice in diabetes technology. So the summary of this CGM, the guidelines are increasingly recommending CGM in people with both type 1 and type 2 diabetes. In people with type 2 diabetes receiving any type of insulin regime, CGM with appropriate support is beneficial. And in people not receiving insulin, it can be very helpful in understanding the best treatment for each individual. Access to CGM should be right and not a privilege. CGM is an empowering device for patients. We know SMBG, advantages of SMBG, as I told, because it's easy to do, bedside you can do, wherever you want to do, you can do. But the disadvantage is painful finger pricks every time. It can be inconvenience to many patients if they are traveling. And the cost, if you see the amount of SMBG you do, when you look for CGM, it will be much more than that. Risk of infection, poor wound healing, emotional toll, varying accuracy because of different brands, no real-time data, that is the most disadvantage, and limited diabetes care support and patient training in many regions. So the RNA-based diagnostic innovation, the next part, you can see the new frontier in
Dr. Aravind, another
Yeah.
2 minutes. Yeah,
I'm done.
You are done, sir. Okay.
In diabetes diagnosis is the RNA-based biomarkers and circulating RNAs in biofluids. So the coming up, you can see there are many new frontiers which are coming up in the diagnosis of type 2 diabetes. There are amino acids like then we have got alpha hemoglobin. These are all the future aspect. I'm sure in next decade we'll see so many different thinking about type 2 diabetes, diagnosis and management, evaluation, monitoring. All this is going to change eventually because we are learning more and more with regard to diabetes mellitus. You can see LGPC is there, leptin levels you can assess the severity of the disease and complication. Then we have got adiponectin and futin A levels. Then BCCA, that is branch chain amino acid, and we have got futin A. All this can be seen, assessed. Based upon that, you can assess the severity of the disease. Adiponectin is there, CRP, carnitines. All this plays an important role. These are coming up as a new frontier in diagnosis of type 2 diabetes. Technologies under development for minimally invasive and non-invasive glucose detection. You can see there are so many technologies: surface plasmon resonance, optical polarimetry, optical coherence tomography. All these are coming in future. I'm sure this will revolutionize the diabetes diagnosis and treatment. cost will always be a factor. I am sure in the over a period of time that can also be reduced accordingly. Thank you for your patience hearing. If you have any questions, we can discuss now only, because as I need to go to a function, kindly ask if you have any question. Over to Dr. Pratibha, please.
Thank you so much, Dr. Arvind. Very beautifully, you have given the insights into the newer frontiers in diagnosis and monitoring of type 2 diabetes. So you have given a very lucid presentation about use of HbA1c in the recent developments, particularly, and the advantages of OGTT, particularly for beta cell dysfunction and insulin resistance, ITT. You highlighted on other glycated proteins, and extensively you have covered about CGM, continuous glucose monitoring, advantages, disadvantages over the conventional glucose monitoring systems. And you have exposed us to the newer technologies as well as the upcoming biomarkers, RNA-based biomarkers, and many others. Thank you so much. I have just one question, then I go on to the audience questions. So, in your experience, when you're using continuous glucose monitoring, have you had any occasions where it has failed? So, how do we come to know? Because we asked, it's a self-monitoring system. Are there any instances where the system fails, or have you had any such experience, or it has been a very foolproof system so far?
So 95% of the time there should not be any issue, because when you before putting only, we need to educate the patients as well as their family members about various aspects of CGM. If they understand clearly, there should not be any issue. But in between, if there is an issue, they need to discuss with you, because sometimes the patient may be over enthusiastically do unnecessary things. The sensor may be it may get displaced.
Yes.
Sensor may get displayed. Sometimes the alarm, hypo alarm can be too distressing for few patients. So at that time, what we do is increase the hypo alarm or hyper. For example, if a 75-year-old gentleman comes, we may not put alarm for 180. We are okay with 250 also, because he's already 75. We don't want him to go for hypoglycemia. We may not be strict in that. So we mainly concentrate that person should not go in for hypoglycemia. That time there may be some irritating things for the patients. But if you know the system, if you know the age of the patient, associated medical condition, we can always individualize the patient so that these errors, these discomforts can be avoided. Otherwise, in general, acceptance is good, but nowadays the cost was the factor. I mean,
Yes.
I'm sure in the days to come, it is going to decrease, which should be recommended to all our diabetic patients.
Yes. Thank you so much. So, in your talk, you have mentioned there's a scope to do clinical trials with validating the use of glycated proteins, serum glycated proteins. Secondly, I think there is a need to innovate low-cost continuous glucose monitoring systems, and also to establish ranges for Indian patients across the various ages. I think these are some of the areas where we could conduct an elaborate research. Thank you, sir. Any questions from the audience? What is the cost of CGM? Is it feasible for the common patients in our country? There's one question, sir.
Yeah, see, cost is around 5,000. 5,000. But the thing is, see, certain conditions are there. For example, patient comes to you, sir, my sugar is not coming under control. So early morning I check, I am in severe sweating, I am trembling, my sugar is low, like that. At the same time, the same patient will say, sir, evening my sugar is around 300, sir, what to do, sir? I don't know. Very erratic is there, hyperglycemia. Sometimes this hypoglycemia is so severe, they may land up in admission. Sometimes the severity is so bad, they may land up in ICU also. Imagine the cost there. If those group of patients at the moment, we definitely recommend, so that we can identify when the patient is going low or high also. So where economy plays an important role in our country, right now what we are doing is we are not advocating to all the patients. We are giving an option. We are giving an option so that if they are affordable, definitely they can go for. But definitely we recommend to do in these erratic cases. So cost is always a matter, but yes, we can. But right now we have to adjust according to the patient needs, patient's economy, and do it for the betterment of patient care.
All right. So, Rubina, does sensor have lifespan? If so, how often does it need replacement?
14 days is the one thing now it is there. 14 days after that, it is not reusable. It's a disposable one.
Disposable one. Yes.
Yeah.
Lifespan. I think with that, thank you so much, sir. You can carry on with your work. Thank you
so
for
much.
sparing time. In spite of your busy schedule, you have given us this much time. We are really thankful to you, and we hope to have more such lectures from you from our platforms. Thank you so much.
Thanks,
sir.
I'm very sure, like dynamic next speaker is there, Siddharth is there,
Yes.
Shambo is there. So definitely they'll be doing a good job.
Yes.
Both of them are dynamic persons as far as know. They are in constant academic activities. They present in various forms. They do clinical trials, publications. They're very, very active guys. I'm sure they will carry on a good messages forward as well. Thank you for making me a part of this, Dr. Pratibha. Thank you once again, and good wishes for the Akshaisarathi Foundation, and good wishes to Siddharth and Shambo as well.
Thank you, sir.
Thank you. Now we move on to the next speaker. Actually, Dr. Jyotirmoy Paul, we were expecting, but he's held up. However, he has sent his slides. Dr. Siddharth, I request you to project his recorded video.
Yeah, 1 second.
Yeah. So Dr. Jyotirmoy Paul's topic is tailoring diabetes management for the geriatric patients. And by the time he projects the slides, I would like to briefly introduce So Dr. Paul Jyotirmoy Paul is a professor medicine college. He's a professor of medicine in College of Medicine and Sagur Datta Medical College. He's MD FRCP London and FRCP Glasgow. He is President Association of Physicians of India, past Dean Indian College of Physicians. He is Scientific Chairman and Organizing Secretary APCON to 2025. Ex-Secretary and Editor, Journal of Indian Medical Association, Joint Finance Secretary, IMA, headquarters stationed at Kolkata, Council Member, West Bengal, University of Health Sciences. He has more than 120 national and international publications. He is Editor-in-Chief for Medicine Update, Progress in Medicine, and McMaster Book of Internal Medicine, South Asian edition, Tropical Fever, Dengue, Differential Diagnosis of General Practice. These are all the topics he has covered, and he has also given various lectures on OSCE for medical practice and other areas in respiratory medicine. So that is in brief, and he was very much interested, but he has got held up in Jaipur, and his flight was delayed. So we will, but he has sent his recorded video. We will just listen to his lecture. If there are any queries, there are other experts in this group, and then we will send it to him also. Yes, Siddharth, you can
Yes.
go ahead.
Everybody, and welcome to this important webinar on diabetes. Why every physician in India now should learn diabetes properly. If you go back 80 years back, 1947, during the period of independence, mortality of 2/3 of the population was due to infectious disease and 1/3 non-communicable disease. The reverse in this century, 2/3 mortality due to non-communicable disease and 1/3 due to the communicable disease. And among the non-communicable disease, diabetes plays a central role in occurrence of the different diseases and complications of these diseases. So, learning of the diabetes is very important. But why diabetes in elderly? At present, elderly population is 13%, but it is going to be almost 30% in 2050. So, coming days physicians, management of different diseases from the elderly perspective should be the bread and butter. So, within the next 12 to 15 minutes, we'll discuss diabetes in elderly, whether in difference of management and diagnosis from the young adults. So, I told in the beginning that due to the advancement of the lifestyles and there is a discovery of the medicines and public health measures, life expectancy, which was 34 only in 1947, now it has increased near about 67 to 68. So India is harboring a good number of almost 30% of the elderly population, and which is expected to be reached around 30% in coming days. So also prevalence of the diabetes, that is also increasing. So we need a review whether geriatric diabetic should be treated somehow differently from the younger counterpart. Elderly population is basically a heterogeneous group of people with a varying physiological profile, functional capability, and life expectancy. And for the diabetes, there is both decline of the beta cell mass and insulin resistance. So when we deal with patient with diabetes in elderly, so two situations can happen. Either diabetes develop in his middle age, now that patients have entered in the geriatric age group, or diabetes first time develop when he is in the geriatric age group. So there is some difference in the pathophysiology and the presentations. When the diabetes start in the middle age and that patient entered in the geriatric age group, basically this group of people has a more increased fasting hepatic glucose production and increased insulin resistance. And these patients have a more metabolic complications and atherosclerosis. Whereas the first time when the diabetes develop in the geriatric group, there is a hepatic glucose production is more or less normal. But there is a more postprandial hyperglycemia rather than fasting hyperglycemia. And this group of patients have suffered from more hypoglycemic and hyperglycemic crisis. But CV outcome in both of the group is almost same. That means the group that develop diabetes in the middle age have both fasting and PP is mid-range, but when the diabetes first time happen in the geriatric age group, postprandial blood glucose is mostly impaired. So now we discuss what are the diagnostic criteria, what is the target goal, very important, issue of the hypoglycemia, clinical evaluation, lifestyle changes which is required, selection of the drug, and very important in geriatric education and role of the caregiver. So first we are coming to the issue of the diagnosis. As per the WHO and ADA criteria, there is a age-limited change. I told the postprandial blood sugar is mostly changes. The fasting blood sugar changes by 1 to 2 milligram DL per decade, but postprandial changes 15 milligram per DL per decade. So in elderly population, if we try to screen diabetes only by fasting glucose, there is a chance of underestimation. That is why in elderly population, when we go for screening, you should do both fasting and postprandial blood sugar. So ADA recommend that above the age of 45 years, every 3 years, fasting blood sugar should be screened. But if the patient is above 65 annually, then screen both fasting and postprandial, and that should be yearly. But patient have other risk factor, there the screening should be more frequent. Suppose patient has at the age of 55 suffer from AMI or some stroke, patient has dyslipidemia, there the monitoring should be more frequent. Now very important is the target. How much blood sugar control is required in a diabetic patient? The previous guideline was the 7.5 in case of elderly population, not very strict control is required because of the issue of the hypoglycemia that I will come later on. So elderly population hypoglycemia is very dangerous. It can further decrease the cognition and also can reduce the incidence of the cardiac arrhythmia. That is why if the blood sugar is 7 to 7.5 in otherwise healthy elderly, as per ETA 2025, it is optimum. But with the geriatric population intermediate health, 8 to 8.5 is quite considered optimum. But if the patient has a major comorbidity or life expectancy is very short, that time the target goal depends on the physicians. The physicians will decide how much blood sugar control is required for that person. Ordinarily, fasting between 100 to 160 and postprandial between 110 to 200 ordinarily is considered optimum for this patient because prevention of hypoglycemia, patient's awareness is low, patient caregiver may not be adequate, patient may have not capability of self-monitoring. So slightly higher side of sugar to prevent the hypoglycemia and its related complication is a major issue. So physicians should decide what should be the target goal. Ordinarily, geriatric population, to remember, with healthy elderly population 7.7.5, elderly population with intermediate health 8 to 8.5 is considered quite optimum. Clinical issue, diabetes is often missed in elderly. These are presenting symptoms often non-specific. When first time admit or come to the emergency with hypoglycemic or hyperglycemic crisis. Even the reduced cognitive function may be the presenting feature. My father was okay or some mild cognitive impairment, but see suddenly last 6 months memory acutely decreased. So reduced cognitive function, acute decrease of the cognition, that can be the presenting feature. Otherwise, recurrent UTI, nocturia, confusion, dizziness, recurrent fall can be the other presenting feature rather than the classical features of diabetes. The issue of hypoglycemia, many times we discuss, because in elderly, hypoglycemia issue is very important because recurrent hypoglycemia decrease the cognition level and also lead to the recurrent cardiac arrhythmia. Both can be increase the mortality and morbidity of the patient. So diabetes related issue or causes of hypoglycemia is renal impairment, which the elderly frequently suffer, and if you give the anti-diabetic drug, patients suffer from hypoglycemia. Concurrent illness, liver disease, undernutrition, dementia, autonomic neuropathy. Due to the autonomic neuropathy, patient often do not feel the hypoglycemic symptom. And concurrent illness is very important. When the patient is suffering from full-blown sepsis, insulin requirement is very high. But if you do not regularly monitor when the patient will improve from sepsis, insulin requirement decreases. So if you maintain the same dose, patient will suffer from hypoglycemia. Dietary related, patient take a lot of alcohol, do not take the food, or errors in the composition of the diets, and others, polypharmacy, one of the very important, some of the elderly patients often take the 20 to 20 drugs, and combination of drugs, polypharmacy can reduce or increase the efficacy of the other drugs. Use of the sedatives, complex regimens. So this is the drug related, therapy related issue of hypoglycemia. I told that hypoglycemia leads to cognitive impairment and nocturnal hypoglycemia. So that is why most of the trials have demonstrated no adding benefit with a tight glycemic control. That is why ADA recommends ordinarily 7 to 7.5 can be the optimum in elderly population. Renal insufficiency increases with the elderly, particularly in presence of diabetic and hypertension. So it should be very cautious when you are giving the drugs. Beta blocker should be avoided in elderly patients because the hypoglycemic symptom may be masked. Treatment, I told treatment should be individualized. Target of treatment is to control the hypoglycemia, to prevent and treat the complication. Education and self-care is very important, and overall healthy status of the to be restored in a geriatric population. So when you are considering the drugs, you have to take care of the age-related physiological changes, the comorbidities that the patients have, cognitive, visual, functional, physical function, socio-economic situation, and life expectancy. So first issue, it should be there should be the accurate, appropriate, available, attractive, achievable, affordable, and absorbable. This should be the basic goal of the diet. So you have to prevent the undernutrition, obesity, then sarcopenia, frailty, total calorie, risk of hypoglycemia, taste, constipation, chewing. All these factors to be keep in mind when you are advocating the the diet. Exercise is very important for the elderly. Elderly with diabetes have a normal cognition. They should work. They should work at least 3 days per week should be the adequate exercise for the elderly, and this should be advocated at least 150 minutes per week. And the aerobic exercise, that is the ideal for the elderly. Next, selection of the drugs. So there are the battery of the drugs. One is the bivonide, sulfonylurea, alpha-glucosidase inhibitors, for inhibitors, that is the beta-jones, insulin, GLP-1 agonist, SGLT2 inhibitor. These are the drugs in your basket for treatment of the diabetic patient. So we are coming one by one. First is the metformin. It is very effective in reducing the insulin resistance, and this should be considered in most of the guidelines as a first line of therapy. But inappropriate use, or suddenly if you give the higher doses, elderly patient may become anorexic and can lose weight. And another issue is the vitamin B12 deficiency, particularly if the patient is vegetarian and not taking the adequate diet. So in case of metformin is a very good drug because in the elderly insulin resistance is a major issue. So should be considered first line of therapy, but initiate with a low dose so that patient can tolerate from the GI viewpoint, and if required, you carefully uptitrate. Then the sulfonylurea problem is the two issue. One is the weight gain, one is the hypoglycemia. Elderly population is frequently suffer from the renal dysfunction, and usually sulfonylurea has a long half-life. So in presence of long half-life, in presence of renal compromise, so if you suddenly give the drugs without proper monitoring, patient can end up with hypoglycemia. That is why the sulfonylurea is not considered the first line of therapy, rather than in the guidelines, whether IDF or it is the second line of therapy. Alpha-glucosidase inhibitor, this is a good drug from the viewpoint that hypoglycemia is very rare, but for postprandial blood sugar control it is good, but problem is a GI disturbance. And elderly frequently suffers from multiple GI disturbance. I have acidity, I have indigestion, I have constipation, I have so and so. So after giving the alpha-glucosidase inhibitor, if GI disturbance increases, that is also disturbing. And there is a drug called, that is one is the glutathione. Glutathione, the problem is glutathione because it increases the edema and exacerbate the heart failure and increase the osteoporosis and hip fracture. That is why glutathione is not considered an ideal drug, though it reduces the insulin resistance. GLP-4, SGLT2 inhibitor, SGLT2 suitable because the elderly population often suffer from the different heart diseases. And SGLT2 inhibitor, one point you have to keep in mind because of the recurrent UTI. So carefully you just assess whether the patient has a history of recurrent UTI. Otherwise, the SGLT2 inhibitor is good for the elderly population unless there is a GFR below 30. Insulin should be started in a certain situation, particularly if the patient first time present with the hormone decay, sepsis, AMI, CKD, or patient is critically ill or awaiting for the surgery. So usually poor glycemic control patients with the fasting blood sugar more than 250 or PP sugar more than 300 or A1C more than 9.5, you should start the insulin. Basal insulin, how we start? Start with usually the basal insulin. And basal insulin with OHA can be combined. Gradually, you can withdraw the OHA and add the short-acting insulin. But the best is the issue of hypoglycemia to prevent. Start with the lower dose, gradually you uptitrate and regularly monitor the blood sugar. Preferably the self-monitoring, blood glucose monitoring is the best in case of elderly. So in summary, the lifestyle changes is a must, diet and exercise. Start with a single agent with half of the recommended doses. Metformin should be the first choice. If it fails, gradually add on with the other drugs. Usually sulfonylurea and glutathione should be avoided, not in the first line of therapy. Use insulin when indicated and encourage to take insulin if it is advocated. Previous guidelines, there was slogan that add years to life, but now it is told by the WHO, add life to years. So 2003 guideline they advocated geriatric guideline, use of aspirin in a diabetic guideline, awareness of tobacco, control of the hypertension leafy, eye care, foot care, self-management, diabetic education. But 2013 geriatric guideline and ADA 2005 line given more importance of cognitive assessment because the slogan is add life to years to avoid the depression, polypharmacy issue, prevention of the recurrent fall, and prevention of urinary incontinence. So aspirin, smoking, control of hypertension, lipid management, eye care, foot care, neuropathic pain assessment, neuropathic spinning, and depression management. Along with the polypharmacy, you review the drugs. Some of the drugs can increase or decrease the efficacy of the other drugs. So in spite of giving the drug, you may not get the adequate response from the drug. So polypharmacy, whether you are diabetologist, you are giving the diabetes drug, but you assess the other drugs for what the patient is getting. Then only you can give the appropriate drug with appropriate action out of this drug. So in summary, annual screening of depression, dementia is must, hypoglycemic awareness, relaxed glycemic goal in the elderly, screening of the complication, metformin is the first choice, role of caregiver is very important, and overall comfort to the patient is most important. At the end, the caregivers and self-monitoring and education of diabetes elderly is very important. In 2025, there is a two issue, the self-monitoring and continuous glucose monitoring. But in our such a country, India, continuous glucose monitoring is almost impossible in most of the population. So self-monitoring and education, how to measure his own sugar, and training of the caregiver is most important for treating a diabetic patient. So only drug cannot cure the diabetes or prevent the complication out of diabetes in an elderly patient. So you should address the diabetic patient in elderly from all aspects, starting from diet, exercise, drugs, overall well-being, consider his cognition, consider his economic situation, consider his caregiver, self-education. So then only you can give a good life to elderly population. Thank you. God will save the elderly. Thank you.
So that was it. And he's not here. Thanks, Siddharth, for projecting that. And I think it was a very holistic approach he has given us towards management of an elderly diabetic. Dr. Pal has given us guidelines for what should be considered for diagnosis, what is the range of fasting blood glucose, HbA1c, and what are the challenges in the management, particularly the presenting symptoms, starting from presenting symptoms and the association of polypharmacy, comorbidities. He has briefed on and stressed rather on individualized therapy. That was really very interesting. And starting from diet, how we can address the diet, how it should be considered as the history is taken and it is advised, along with exercise, what should be the norm. And also the targets for therapy, apart from HbA1c and FBS and other parameters, he has given a very good guide to assess, apart from the blood sugars, on cognition, depression, dementia, which are going to be there. As he said, we are going to add life to years, and he has very beautifully added on role of caregivers also. And as he rightfully said, in an Indian context, self-monitoring rather than continuous glucose monitoring and patient education makes a big difference And therefore, this topic was definitely addressed in a complete holistic way. And I invite questions for we have other speakers on the panel now. Dr. Siddharth is there, and Dr. Shambo, Samrat, Samajdar is there, and other seniors are there as they have registered. So if anybody would like to add on to this, we would be more than happy. If you have anything to add, and if there are questions also, we could take questions and direct them to these specialists and others who are there in the on this platform today. Any questions? Dr. Siddharth, would you like to add something? Anything to be added?
Yes,
Would you
ma'am. So, very commonly in clinical practice, we see a lot of doctors trying to go for tight glycemic control in the geriatric population. That is not recommended, ma'am. It's better to avoid hypoglycemia rather than risk hypoglycemic induced seizures.
Okay.
So it's very, very common. So
Okay.
it's always better to give us, you can always start with a small dose and then you can titrate the dose. That is the common practice, very much seen. And most of the, as you also know, most of the geriatric population, they will not be able to express the symptoms. It has to be noticed by a patient attender who's taking care of the patient. It can never be expressed by the patient themselves. Very common in geriatric population. So that is really something which we have to look out for. So
Correct. That's right. Dr. Shambo, Samrat, are you there?
Yeah.
Anything? Would you like to add anything to this talk?
Yeah, I think most important part is, I think one of the slide Professor Paul has mentioned also, the tight glycemic control is not at all required in maximum of our patient. And yes, though we are really fortunate now because we have many weapons in our armamentarium, such oral anti-diabetes agent, which is not possessing the extra risk of hypoglycemia. For an example, DP4 inhibitor, metformin, or SGLT2 inhibitor. We can go up even HbA1c less than 6.5% in some subset of our elderly population too. But when the patient is on drugs which has inherent properties of hypoglycemia, for an example, sulfonylurea or even insulin, that time we need to relax that. And very recently we had published one paper in Diabetes Care, the official journal of American Diabetes Association, on the deprescribing strategy in elderly population. When the in one slide, Professor Jyotirmoy Pal has mentioned about polypharmacy, and it is important to deprescribe unnecessary drugs, redundant drugs, and we need to reconcile the prescription as much as possible. And we had used one mnemonic. I think if you were interested, you can go through that. It is a freely downloadable article in Diabetes Care on deprescribing. So you can get, and I can also share the link with you, madam.
Yes.
So I think this is an important aspect when to deprescribe, because once as polypharmacy, the patient may take some certain other group of drugs. For an example, Professor Pal has emphasized the dementia part, the cognitive decline part, but we can take some drug which may potentiate this problem. Those
Yes.
drugs are called high anticholinergic burden drugs. For an example, from our OPDs, medicine OPDs or diabetes OPDs, to treat diabetes neuropathy, as there is no alternative freely available, amitriptyline is available freely. So they are prescribing, or patient is getting amitriptyline. But unfortunately, amitriptyline is having a very high anticholinergic burden of 3. So it will potentiate the problem of cognitive decline. So that is why it is not only just to check what are the anti-diabetes agent patient is taking, but also you need to assess the other drugs, the prescription risk, whether the patient is having some drug carrying potentially inappropriate prescribing risk. So we need to assess those and we need to deprescribe those.
Yes. Very well said. Yes. So with that, I think if there are no questions from the audience, any questions? Okay. We'll move on to the next talk. We have Dr. Shambo Samajdar, Samrat Samajdar, and he'll be speaking on the Odyssey of insulins, because we have heard now, and we have been talking about this since the time of discovery of insulins, but it has undergone a lot of developments, particularly in the types of insulins, in the insulin delivery systems, so many. So let's hear from Dr. Shambo Samrat Samajdar, who is consultant physician. Is my slide seen? Are you able to see the slide?
Yes, ma'am.
Yes. So he's MBBS, MD, DM with PG diploma, and he's a gold medalist, DM in clinical pharmacology, PG diploma in endo and diabetes. Is my slide on introduction seen, Siddharth? I've projected this slide.
Not the introduction, ma'am.
Introduction, I want to project this. Yes.
Introduction was not there.
Okay.
Yes.
Is it seen now?
Now seen,
Yeah.
ma'am.
Yeah, so he has got fellowship in respiratory and critical care, and he has got gold medals in these in diploma in allergy, asthma, immunology. He has published more than 148 articles in index medical journals, and he has authored competency-based practical pharmacology, diabetes in practice, and many other publications. And most important is he is kept up with the pace of artificial intelligence for physicians, advances in MASLD, comprehensive guide for physicians, more than 80 book chapters, and a fellow of Indian Pharmacological Society, Indian Academy of Diabetes award. He has received Innovation Award in 2022, and he has got another award, JC Patel and BC Mehta Best Paper Award, and another one is WIDF Innovator Award from Mayo Clinic and CDRI Oration IPS 2024, RSSDI Innovation Award, Governors Recognition, ACP India Chapter. He recognition for India Chapter Research and Publication 2024. He has also received Most Promising Young MD Pharmacologist Award from MPS 2024, Young Scholar Award 2024. So with so many awards and so many areas of his work, we are it's really very commendable to see his contribution in both clinical pharmacology as well as in the clinical practice, particularly in the areas of diabetes and respiratory medicine. Over to you. Thank you so much. And I welcome you, Dr. Shambo Samrat Samajdar. Another one thing I have to tell about him is he has got a deep interest in spirituality, and we often discuss few aspects which are very much essential in today's world, which is involved in multiple and handling multiple tasks and getting exposed to different challenges in life. So he has a deep interest, and he has published several papers in this area also. And I think in the Speaking Tree of Times of India and other publications which I have come across. So thank you so much, Dr. Shambo Samrat. We are indeed lucky to have you, fortunate to have you in today's panel. Over to you.
Thank you, madam, for your kind introduction. And I think, can you please allow me to actually share my screen? I don't know whether...
You can share screen, entire screen, and click on the minimized PPT. Share screen first. Yeah, entire screen.
My slides are visible?
No, not yet.
Now?
No, not yet. Not yet. I think it will go. You should click on the PPT now. After entire screen, you click.
He has left the meeting. I think he'll come back.
He'll rejoin. Yeah. Dr. Shambo, you click on entire screen and then click on the PPT, minimized PPT. It will come. Yeah, now now it's there. Yes, please go ahead. Slides are seen. Yeah, you can unmute. I think you have muted. No, that was fine.
Yeah, am I audible?
You're audible. Slides are now. Now it's yeah. You're audible
And
now.
it's
Yes,
changing.
yes, yes. Please, it's going.
Oh.
Changing. Yes.
Yeah, thank you, madam, for your kind introduction, and I'm really thankful for giving me this opportunity to discuss this important topic, the evolution, the history of insulin, and also I will touch upon certain pharmacokinetic, pharmacodynamic insights which could guide us in rational prescribing. So let's start with history, and I think the beginning, if we want to talk about it, is 1889. So Oskar Minkowski and Joseph von Mering had observed that a dog developed diabetes with the characteristic of symptoms of the disease after total pancreatectomy. This finally confirmed the central role of pancreas in the etiopathogenesis of diabetes. Then in 1901, Eugene Opie discovered that the specific cells in pancreas are responsible for developing diabetes. So diabetes, the life before the discovery of insulin, was mostly very unfortunate. The most effective treatment was to put patients with diabetes on a very strict diet. So you can see in this particular slide the starvation treatment of diabetes on restricted carbohydrate intake, and sometimes patients die of starvation itself. We can see the mother with diabetic child in 1920s. But this was the discovery. If we can quote Professor Ilian Jocelyn, who had delivered this lecture 40 years after discovery of insulin, he mentioned 40 years with insulin and 4,000 years without. Today, there must be 3 million people with diabetes whose lifespan has increased on an average at least by 10 years each. This makes a total of 30 million years of productive human life in one country alone. So, what are the important landmark event that happened? So, November 8, 1920, first time Banting meets McLeod. So, 31st of October, Banting had that idea, and Banting opens medical practice in London in 1920s. And what happened? He visited also the Toronto on 1922. Eli Lilly, first time with that proposal, with that thinking, ships the insulin to Toronto, and patent application was done with the help of Collip and Best. The publication of the results was on 1922, and the January 23, 1922, the activity of the purified extract in a human was first to be seen. So Banting and Best begin the experiments in 1921. The activity of crude extracts in a pancreatectomized dog was done in July 30, 1921. August 27, 1923, we know the favorite picture. This is the diagram that had been appeared in the Time magazine, and 1923, October 25, Nobel Prize awarded to Banting and McLeod. And they had shared their award with Collip and Best. So this is the most cherished moment, and we need to acknowledge this fantastic feat of insulin delivery. In this particular slide, what we can see, the discovery of insulin significantly improved life expectancy. following the discovery of insulin, the average life expectancy of a person diagnosed with diabetes improved dramatically. So by 1945, a child diagnosed with type 1 diabetes at the age of 10 could expect to live more than 30 years longer than a 10-year-old child diagnosed with type 1 diabetes before the discovery of insulin. So that extra 30 years given by the insulin. Now we know we have newer technologies, we have automated insulin delivery system, where by the virtue of them, now the type 1 diabetes can live longer. So these are the three important landmarks also we need to acknowledge in the journey of insulin innovation. First, discovery of protamine to prolong the duration of action. Then in the 1978 to 1982, we know that genetics evolves and we have recombinant human insulin that time. And finally, when we talk about around 1996, we got different insulin analogs. And why insulin analog is important? Because of their pharmacokinetic characteristics, they are matching with real-time or natural insulin secretion from the pancreas. Before going to the application in the patient, we need to understand the risk versus benefit with each therapeutics. And that is why we need to understand two things. One is supra versus subtherapeutic range and the effect between drug concentration and the drug effect, and drug concentration and its effect with time that need to be matched properly. And this is why we are talking about pharmacokinetics and pharmacodynamics, which matters most in all therapeutics. And in this insulin innovation journey, this pharmacokinetics, pharmacodynamic also, this concept is crucial. Now coming to this pharmacokinetics and pharmacodynamic interface, the insulin is something which generally we understand its pharmacokinetics by its pharmacodynamics, how it behaving with glucodynamics, that is being translated in a back calculation, you can say, the pharmacokinetic property of the insulin. And how this pharmacokinetic of insulin can be changed, that can be changed with this first step, how we are administering the drug. So the pharmaceutics, how we are creating the molecule. Molecule is same, that is insulin, but how we are modifying that depends, that influence the pharmacokinetic pharmacodynamics. So if I am using one human regular insulin, if we are using one human NPH insulin, or we are using Lispro insulin, or we are using Dicludac insulin, the insulin is same. But by how we are applying, how we are changing the presentation of the molecule, and how they are being given in the subcutaneous place, that determines the pharmacokinetic pharmacodynamic of that particular molecule. And that is what we need to explore. So basically the structure of insulin is same. This is two polypeptide chains linked by a disulfide bridges. We know the chain A and chain B here, and chain A comprise 21 amino acid, chain B comprise 30 amino acid, and the basic structure is same. But modifying that, we will talk about it later, by modifying that, the absorption profile changes from the subcutaneous tissue, and by which they will influence the glucodynamics inside us in a variable way. So normally what happened? Normally insulin secretion there is a basal insulin secretion, and that is accounting for about 50% of the total daily production. Apart from that, there is meal related peak. So for an example, breakfast, lunch and dinner will have those peaks. Coming to the 1936 breakthrough, we have the insulin that time, that we can understand the insulin, but it was short acting insulin. Addition of a strongly basic proteins like protamine actually prolong the effect of injected insulin, and longer acting insulin formulations like protamine zinc insulin discovered for the first time. Discovery of lenti insulins with the extent of amorphous to crystalline insulin determining the duration of activity. We need to acknowledge this scientist, Hans Christian Hegdon. From his name only, we got NPH. So NPH insulin in the 1946, first time available as intermediate acting insulin with a slower onset of action but longer duration of action. Originally it was animal source. Today we got NPH insulin, which is made up of human regular insulin. So you can see the structure, the synthetic human insulin, which is complexed with zinc and protamine, and that make it little bit cloudy. What are the challenges with NPH insulin? Yes, it is insufficient in terms of basal insulin coverage. We need at least 2 injections per day, need for resuspension, and there was significant day-to-day variability. That is why we need more once daily molecule, once daily basal insulin, and we got first generation analog like insulin glargine U100. So first time it was approved in US 2000. So from 1936 to 2000, long time. And you can see the highlighted chain that happened with the A chain and B chain, how the arginine being changed, arginine being introduced, and glycine being changed. So what happened? The subcutaneous injection in an acidic solution, the pH 4, there would be a precipitation of glargine in subcutaneous tissue and slow dissolution of free glargine hexamers from precipitate glargine, and that will lead to a protracted action. So you can see the difference in this image, the NPH insulin and insulin glargine, how much it is protracted in its action. Here we want to highlight again that the basic thing is insulin. As we are injecting in our subcutaneous tissue, now the formulation with which we are injecting it in the subcutaneous tissue, that actually influence this change in pharmacokinetic pharmacodynamics. Coming to another long-acting insulin, that is Tetemir, which also we can see having a C14 fatty acid chain, the myristic acid. So subcutaneous tissue to circulation and then interstitial fluid. So there is a major protraction, self-association plus albumin binding, and there could be a minor protraction also in the circulation because of albumin binding. But when it reaches interstitial fluid, there is no further significant protraction. So higher day-to-day glucose variability, which was there within pH, that for the first time being solved with these 2 basal insulins, one is glargine and another is Tetemir. Coming to first generation analogs, when we talked about, that means glargine U100 and Tetemir, they are not truly once daily molecule. They are having higher variability. Yes, they have less variability compared to NPH, but we need more control in the variability. Fixed time dosing. And we can see there is certain level of peak. So it is not truly peakless. And there were incidences of higher nocturnal hypoglycemia. To solve this, we need something more prolonged in action. So insulin digludac, which is having a mode of protraction like in this way, injected in a dihexamer formation. Now, as they have phenol, the phenol will go off. Rapid phenol depletion after injection results in they will form a multi-hexamer chain, as we can see here. Now the zinc will diffuse slowly, causing individual hexamers to disassemble. And after deassembling, they will release the dimers and monomers. Now the monomers will be absorbed from the soluble depot into the circulation. By this mechanism, the digludac will have a long action. Coming to another new generation or second generation basal insulin. Threefold concentration. So the glargine U100 we have, now we have glargine U300. It is threefold concentration. This version of insulin glargine was developed to prolong the duration of action. We can see in this picture the insulin effect of glargine U300 here, and the red line was glargine U100. What happened? In the glargine, when we are injecting, it is glargine, but we are injecting it in a smaller volume of injection. When it becomes in a depot formation, and as it will be a smaller volume of injection, more compact subcutaneous depot with a smaller surface area, and that will lead to gradual and slower release from the depot surface. That is why it has a prolonged duration of action. Precipitation, which is a marker of substantial glycemic variability, and I think this is important to understand. In this cartoon, this image, we can see insulin glargine forms microprecipitates after subcutaneous injection, which must redissolve before absorption occurs. And that is why the glargine U300, having dilution in the subcutaneous space, the pH-induced precipitate upon injection, so slow dilution to monomer. Not like that the glargine U100. So the precipitation and redissolution are processes inherently associated with substantial variability. Formulation that do not precipitate after injection, they will have lower day-to-day variability. And that is why, as we can see in this picture clearly, this formulation, they will not precipitate after injection very faster way. When we talk about glargine U100, they will have a more faster precipitate. So coming to the clinic-based knowledge that we should have, glargine U300, the onset of action is around 2 to 6 hours. Duration of action is definitely more than 24 hours, 30 to 36 hours. Whereas digludac, it has onset of action around 0.5 to 1.5 hours. Duration of action more than 42 hours. And if we try to compare between U100 and the new generation basal insulin, we can see there is a peak of action with glargine U100 too, and the duration of action is not through 24 hours. Yes, theoretically it can reach 24 hours. So digludac has a faster onset of action and prolonged duration of action versus glargine U100 especially, and U300 in some subset, and it is peakless compared to glargine U100. This is again a very important clinical tip we need to acquire, that for the digludac, we could have a flexibility of 8 to 40 hours. because we had mentioned it is 42 hours acting. So the flexibility also, it is 8 to 4 hours. So it is not that I have to keep it every day at 10 p.m., which is for glargine U100, we need to give it in a specific time point every day. So there is no flexibility. For U300, we could have a plus minus 3-hour window. But for Digludac, the flexibility is more. So patient benefit, obviously it was there. The NPH in 1936, we can see their peaks, their how they were. For the first time, we had something which can control the fasting hyperglycemia, but it should be given at least twice daily, and risk of hypoglycemia was there. Then we got U100 and Detemir, as we had mentioned. But glargine U300 and Digludac had revolutionized the basal insulin therapy. So once weekly versus once daily basal insulin therapy, I think now we are getting chance of getting chance to prescribe our patient once weekly insulin therapy. So clinically, it is important to have better glycemic control with low hypoglycemic risk, to reduce treatment burden, to improve the efficiency of the therapy so that it could overcome the therapeutic inertia. So molecular way, if we get it through the longer half-life, having better stable pharmacokinetic, pharmacodynamic characteristic, slower clearance rate, nothing like that. So better treatment acceptance and adherence will be there with once weekly therapy. So which was there in 1920. Now we are also moving towards inhaled insulin. I think very recently we got the approval, but it is not commercially available, I think, to our patient. And it requires thorough investigation, more real world data also we need to have, so that we could have our perspective, clinical perspective. And then we also need to talk about certain modification in the basal insulin therapy, because bolus insulin therapy, we had already discussed a lot about basal insulin therapy, but we also need to talk about bolus therapy, which actually tackles those post-meal hyperglycemia. Post-meal hyperglycemia control is also important, just like our fasting control. So for that, we had a different bolus insulin. Initially, we have the regular human insulin, but then what happened? From the normal pancreas, the nature of the insulin therapy, insulin secretion post-meal is like the blue line. What we have, the rapid-acting insulin analog, they mimic the normal pancreas derived bolus insulin secretion. But now we are moving from rapid-acting insulin to ultra-fast insulin. Why ultra-fast insulin is important? Because we could have a better approach in physiological insulin secretion, better early glucose lowering effect, better glycemic control, and lower risk of late hypoglycemia. So we had Lispro there, which is a fast-acting analog. And we can see the modification here in the beta chain, especially the proline and lysine, which is being switched at 28-29 position. It was there from 1996. Onset of action is around 30 minutes and effect ends around 5 hours. So when we talk about insulin aspart, we had already discussed these changes, and that changes, that pharmaceutic change actually tells or translated into the pharmacokinetic property of this insulin molecule. Most importantly, this is applicable for the pregnancy also. It is safe during pregnancy. Coming to glulisin, which is the asparagine in the third position in the beta chain, is replaced with lysine, and lysine at 29th position is replaced with glutamic acid. That was the pharmaceutic change happened, and we got glulicin. So what are the important point here? The key difference as compared to other insulin is weaker monomer-monomer interactions that lead to faster bioavailability. And if we want to understand the regular human insulin, the timing is very important. We should tell our patient the regular human insulin need to be administered 30 to 45 minutes before meal. And it creates logistic difficulties. It can cause hypoglycemia or late postprandial hypoglycemia. Most importantly, it also impacts in patients who are having autonomic neuropathy, especially associated gastroparesis. So ideal postprandial blood glucose level, to achieve that, it is important to get the right insulin dose and at the same time, right injection timing. So when we talk about aspart versus regular insulin, be it aspart, be it glulicin, the improved pharmacokinetic profile actually help us to reach the mealtime flexibility, greater glucose lowering effect. The improved safety and efficacy of insulin aspart had demonstrated multiple randomized controlled trials, including various patient phenotype with type 1 and type 2 diabetes. And the most important outcome was that the hypoglycemic episodes was less. The severe hypoglycemia was much less. And stepwise intensification is an appropriate treatment option with insulin aspart. So from rapid acting insulin, we are moving towards now to the ultra fast acting insulin, more mimicking to the physiological bolus insulin secretion. Yes, we could have the sprinkler needle, the inhalational insulin, but at the same time, the other formulation modification that could influence the pharmaceutic of ultra fast insulin. So I shall tell you the example of a faster aspart, which is nothing but insulin aspart, but in a new formulation. The niacinamide, which is an absorption modifier used there, with L-arginine, which helped to make it more stabilized. And that is why we can see, I think all of you will appreciate the type 1 diabetes patient. They are the ideal model to understand the pharmacokinetics of the insulin. And here we can get 74% greater insulin action within the first 30 minutes. And that is statistically significant. Whereas in the type 2 diabetes model also, 147% greater insulin action within the first 30 minutes. So twice as fast onset of appearance in the bloodstream, almost twofold higher insulin exposure within the first 30 minutes. So again, please think that the pharmaceutic modification of insulin that will make a better absorption profile and better glucodynamics in terms of this type of insulin. So patient benefits with evolution of mealtime insulin. We had regular human insulin. Then we have fast-acting insulin aspart, lispro, glulicin. And now we are getting second generation insulin, which are faster acting. We have insulin aspart, which is faster acting. So they
Dr.
are,
Shambo?
I
Dr. Shambo?
yeah, by 5 minutes or 2 minutes.
Another 3 to 4 minutes.
Fine. So fast-acting insulin aspart, they mimics the physiological mealtime insulin secretion, better control. Now we are talking about not only the 2-hour postprandial glucose control. We are highlighting the importance of 1 hour postprandial glycemic control. And I think today we had a beautiful discussion on continuous glucose monitoring, the CGM. And there also, it is important to take care of the 1 hour postprandial hyperglycemia. And on that issue, this ultra rapid acting insulin, analog insulin, are important. So we had talked about faster aspart. Now we also have the ultra rapid listro, mimicking the fast acting insulin profile. So here again, the formulation being changed, pharmaceutic modification done, treprostinil and citrate was used as absorption enhancer for the insulin listro. So if we want to compare the prandial insulin now, we had regular human insulin, we have insulin aspart and faster aspart. So the journey started with short acting insulin, then we get rapid acting analog, and now we are having ultra fast acting analog. And there the evidences tells us that post meal dosing is also possible with this faster aspart. Yes, it was there with glulicin too, but now faster aspart also we can administer up to 20 minutes after the start of the meal. Why it is important? It is important because many of our CKD patients, many of our hospitalized patients, they will have vomiting, they will have nausea. So pre-meal insulin already given, patient is not taking proper meal, or patient vomits after taking meal immediately. What will happen? There will be hypoglycemia. But if we can understand that, okay, the patient will take the meal, we can wait for 10 minutes, then we can use the bolus insulin. So that actually take care of those concerns which may be due to with the vomiting followed by meal intake. So we are having more physiology mimicking analog insulins. And I think lack of time, I shall not talk about premix insulin, but it is important also today to understand the dual release insulin concept. So one should be the fast acting insulin, and another would be the basal insulin. It will reduce the injection frequency, and that is why the premix insulin, which could be used to control the fasting and postprandial hyperglycemia. But at the same time, we need to acknowledge the limitations in terms of lack of flexibility. So they are having both component, one rapid short acting and another intermediate or long acting insulin, but they are having less flexibility. I think these are few important premix formulation in our country. Mostly it is low mix formulation and mid mix formulation we are using. And these are the pharmacology of premix insulin that we need to know while prescribing this group of drugs. IDEC ASP, we will talk the co-formulation little bit. This is the IDEC ASP, the co-formulation which is having a digludac component and one component is aspart. So co-formulation of insulin digludac with rapid acting insulin, it is possible because of stable dihexamers in solution. And that is why one molecule, the digludac, will have slow dissociation and aspart will have rapid dissociation, quicker absorption profile. This is a mode of protraction at steady state. We can see the IDEC as co-formulation injected into subcutaneous space. So there will be one part is aspart hexamer and another part is digludac dihexamer. Now the phenol diffuses quickly and insulin digludac dihexamers link up via single side chain contracts to form the long multi-hexamers. And the when you talk about IDEC gas, the aspart monomers are released into the circulation very rapidly. And when zinc diffuses slowly, that will cause individual insulin digludac hexamers to disassemble, but they will release the monomer slowly. So this is why.
Dr. Shambo, can you conclude? We have another speaker.
Yeah. So
yeah. Okay.
This is the last. I think you can carry on. Thank you.
Okay, that was the last slide, is it? Okay, thank you so much. Thank you, Dr. Shambo, Samajdar. Very beautiful illustrations. You have covered starting from the history, from the origin of insulin till the latest developments, where you have correlated pharmacokinetics with beautiful illustrations of their chemistry and formulations also. And that you have linked with their clinical performance with very good citations. Any questions? If not, and you have also covered about post-meal insulin, which is a recent development. So while administering insulins, do you recommend which is the best mode, continuous glucose monitoring or the conventional basal monitoring, which would be more appropriate for deciding the dose and choice of insulins? That's my question.
Can you please repeat that, madam?
When you want to choose a particular insulin and titrate the dose, which is the best mode? I understand CGM is a costly thing for our Indian patients, but would that be an ideal one, or the basal monitoring would suffice for choosing the type and the dose of insulin?
No, as we had mentioned in the last presentation also, the self-monitoring blood glucose tells us a lot of information. And especially if we talk about the formulation, the fasting and PP, the gap, that will also tell us what insulin we should choose.
Okay.
So basically, the guideline tells us if the fasting and PP gap is high, it is better to start with the premixed insulin, because we need to take care of the bolus part also.
Okay.
But at the same time, there are certain studies, if the patient are newly diagnosed with type 2 diabetes, if we can add the basal insulin part, and on top of that, we can use the certain drugs like DPP-4 inhibitors or certain short-acting glycoside molecules, or even if we talk about repaglinide, if we use those molecules, that also can give you a good control. But it depends on the patient profile, the glycemic parameters, and the self-monitoring blood glucose plays a very important role. What type of insulin we should choose, that will be understood by this SMBG profile.
Ma'am, just one question can I ask?
Yes, please.
Sir, Shambo sir, actually you mentioned about the this intranasal insulins.
Yeah.
Which factors they are hindering their entry into the market, or because they might be easy to use for the patient and we may save some pricks, I think. So what was the thing which
most important part of what I understand regarding the inhaled insulin, one, it is not basal, it is bolus, right? So definitely, as you had mentioned, for those patients who are taking bolus insulin separately, they need at least 3 prick extra. Now, if you have inhaled insulin, it will reduce the prick. But why it is not that favorable for our patient? I think the long-term side effect fear. And I think the data we need, because I shall be personally very much skeptical using this molecule, because we don't know the pharmacodynamics, the effect of it in our lungs for long duration. So that data we need. So and I think that is why it is not being popular also. And for an example, if a patient is suffering from COPD or having some existing lung condition, what will be the effect of that lung condition in insulin absorption? So these are few important areas, and I think that is why it is being delayed. I don't know, maybe it would be some pharma industry derived other issues also, especially if you want only a basal bolus insulin. The bolus if a company only bringing something which is bolus in nature, the market is not that huge. How many of us actually practicing the basal bolus therapy in our patient? So there are certain pharma economic like driven things also, issues there also. That could be another reason.
Thank you, sir.
Okay, so for little shortage of time, we will go ahead with the next speaker, Dr. Siddharth Gosavi. We have another question. I think I will be disappointing. She has asked to give some idea on transdermal insulin delivery, Dr. Shambo. By the time I go to the
so transdermal insulin delivery, I think I don't have any news to share with them. It is not available, I think, clinically.
Okay. All right.
There are certain studies of using insulin in diabetic foot ulcer locally applicated insulin.
Okay.
But transdermal drug delivery or with insulin, I think I don't have any exposure on that.
Thank you very much, Dr. Shambo Samrat. He is also a very busy person with his clinical practice and giving presentations very frequently. And he keeps himself so busy with his publications that I think almost every week we see some new article either in the scientific journals or papers. So in spite of that, he has made time for us. Thank you so much, Dr. Shambo Samrat. Hope to see you again on our platforms in future also. Thank you so much. So with thank you. With that, we move on to the last speaker for the day, Dr. Siddharth Gosavi, consultant in internal medicine. He has done his MBBS from where I was working. He has been my student at Vaidya Institute of Medical Sciences. MD Internal Medicine from Davangere, DNB Internal Medicine, Fellow of Academy of General Education, Fellow of International Diabetes Federation, consultant at Sai Gosavi Speciality Clinic, which is his own. And he also visits Nano Hospital, Saraswati Speciality Clinic. He's a visiting consultant in internal medicine at Kriya Hospitals, Bangalore, academic editor for PLOS ONE journals, peer reviewer for BMC Public Health, Frontiers Journals, Diabetes and Metabolic Syndrome, PLOS ONE, Curious Journal of Medical Science. He has got more than 40 publications in index journals, PubMed index journals, and 546 citations and an H index of 11, authored 2 chapters. He has received M. Vishwanathan Poster Presentation Award at Apicon, Agra, ACP India Chapter Early Career Physician Award, and ACP India Chapter Scientist of the Year Award 2023, and Curious Laureate of Curious Journal of Medical Science. So as previous speakers, this speaker also is a highly accomplished physician. And apart from this, I must say my interaction with him dates back to 2012 from when he was doing his MBBS at Vaidya Institute. And he has been a very sincere student, very committed, and he continues to do that. We have regular interactions. He is on our advisory committee, advisory member. He is advisory member for Akshaisarathi Healthcare Solutions. He has also participated in our previous session on developing research ideas for an undergraduate, because he was one of my ICMR student also. We have chosen him not because he is my student, but the committee has observed his performance, and as you have seen in his CV, he is also, just like Dr. Shambo and other youngsters, a very enterprising physician, very committed. And over to you, Dr. Siddharth. I welcome you for this, and thank you for accepting.
Thank you for the opportunity, ma'am, and your kind words.
Yeah, he's going to speak on type 5 diabetes. I forgot to mention. Yeah, please go ahead.
Is the screen visible, ma'am?
Yes, yes.
Yeah.
Perfect. You can go ahead.
So today I will be talking about a topic which is called type 5 diabetes, which was again recently recognized by the International Diabetes Federation in Bangkok in April 2025. It was in existence earlier, but it was removed by the WHO in 1999, misdiagnosing it as type 1 diabetes. But now it has come to light, and it's a very new phenomenon, and one which has a lot of spectrum, and for which still there is not much existing literature and treatment protocols. So I would like to speak on type 5 diabetes. Yeah. So type 5 diabetes is actually a distinct entity which consists of 3 categories. First is the malnutrition related diabetes mellitus, fibrocalculous pancreatic diabetes, and ketosis prone diabetes. So very common factors are the dietary toxin intake of the cassava, especially, which is also called tapioca, and recurrent pancreatitis and nutritional deficiency, particularly vitamin A, have been implicated in the development of fibrocalculous pancreatic diabetes. And there's a lot of protein related malnutrition which is involved in this type 5 diabetes. So emerging genetic studies have also identified a genetic mutation in the SPINK1 mutation, that is serine protease inhibitor, Casal type 1 gene, which appears to predispose individuals to this condition. So there's a complex interplay of both genetic factors as well as environmental factors. So first, it was described by Dr. Hugh Jones in Jamaica in 1955 in young lean patients with diabetes, but most importantly, no ketoacidosis. Subsequent reports were reported in India, Bangladesh, and African countries, predominantly in undernourished young adults. So in 1985, there was a WHO classification which classified type 5 diabetes into fibrocalculous pancreatic diabetes and protein deficient pancreatic diabetes. But in 1999, it was removed from WHO classification, thinking it to be a variant of secondary diabetes or misclassified type 1 diabetes mellitus. Recently, as I mentioned, in Bangkok in April 2025, the International Diabetes Federation officially endorsed type 5 diabetes at the World Diabetes Congress. So we'll come to the first type, that is the malnutrition-related diabetes mellitus. It is a type of diabetes where there's chronic early life protein deprivation leading to malnutrition and pancreatic dysfunction. Very commonly, adolescents and young adults present with MRDM. There is pancreatic damage leading to insulinopenia, but there is, however, most importantly, no ketoacidosis. So the most important thing here is there is exocrine pancreatic insufficiency with steatorrhea, common in tropical countries where nutrition is poor. Hence, type 5 diabetes is also called tropical diabetes. So the clinical features of MRDM, there's a low body mass index. Patients typically present with BMI less than 18.5 kg per meter square. There's severe insulin deficiency, but decay is extremely rare in MRDM. Exocrine pancreatic dysfunction associated with diarrhea, steatorrhea, and fat-soluble vitamin deficiencies. There's also recurrent abdominal pain, which is very common in MRDM. So the key investigations in MRDM are fasting blood glucose greater than 126 mg per deciliter, a PPBS of greater than 200 mg per deciliter. C-peptide may be low or absent, indicates beta cell dysfunction without any autoimmune destruction. And glycemic profile, where there is hyperglycemia with normal to high insulin sensitivity. There is also a subtype of MRDM, which is called protein deficient pancreatic diabetes. It occurs in the setting of long-standing protein and energy malnutrition, which leads to atrophy of the exocrine pancreas. There's marked insulin deficiency, predominantly seen in individuals with low protein intake, very, very common in South Asian countries and sub-Saharan African countries. The second type, which I would like to touch upon, is the fibrocalculous pancreatic diabetes, characterized by extensive pancreatic fibrosis with progressive beta cell failure. It progresses from exocrine involvement to even endocrine dysfunction of the pancreas. The weight of females would normally be around 40 kg, whereas males would weigh around 50 kg. Average of age of onset is 23 years and above. So when the exocrine insufficiency presents itself, there's steatorrhea, malabsorption, and weight loss. There is insulin deficiency, requires insulin, but patients rarely develop diabetic ketoacidosis. This is the main differentiating factor from type 1 diabetes. So the clinical features, there'll be a lot of abdominal pain, as I mentioned. So when we do an ultrasound or a plain abdominal X-ray, And some cases, we even go for the CECT, contrast enhanced CT abdomen and pelvis. We look for the pancreatic calcifications. Very common in India, Bangladesh, and parts of Africa and Caribbean. As I said before, linked to cassava or cyanogenic diet exposure. There is erratic glucose control with exaggerated postprandial spikes. And nutritional issues also are there in the form of protein and fat malabsorption may require enzyme replacement therapy. The most important feature is absence of autoimmune markers such as the glutamic acid decarboxylase antibody, IA2, the islet antigen 2 antibody, a zinc transporter A antibody. So here in clinical practice, what we've really observed is patients with FCPD, even if there's a small change in the dose of the insulin or even the OHA, there would be a massive erratic change in the blood glucose levels. So it's really important to not look for too much of a tight control, because even small doses of changes in the insulin or OHA, there will be severe erratic glucose spikes. So the key investigations in FCPD are reduced levels of fecal elastase. It's a marker of exocrine pancreatic insufficiency. Amylase and lipase will be elevated. Recurrent chronic pancreatitis, very common. C-peptide levels are low, where there's fasting hyperglycemia, which indicates beta cell dysfunction. The third type is called ketosis-prone diabetes. Extremely aggressive form of diabetes, presents with marked diabetic ketoacidosis at onset itself. Insulin requirement may be intermittent. It is not a lifelong necessity. Has features of both type 1 DM and type 2 DM, but there is no autoimmunity. And where the beta cell function is variable, sometimes it recovers after the episode of the diabetic ketoacidosis. Sometimes it may go for insulin dependence. But the insulinopenia, importantly, is reversible in ketosis-prone diabetes. Again, here, there is absence of autoantibodies. Ethnic predisposition, very common African, Latinoid, South Asian descent. Fluctuating beta cell dysfunction with alternating decompensation and recovery. So insulin requirement, again, is intermittent. It is not a lifelong necessity. So here, the distinctive clinical features are episodic diabetic ketoacidosis may recur many times. Unlike type 1 diabetes, there is no lifelong insulin dependence. As I said, absence of autoimmune markers, negative for the GAD, IA2 and ZNT8 transporter autoantibodies. BMI profile, patients may have normal or elevated BMI. Unlike MRDM, where there is low BMI, there's a variable beta cell function. Some regain near to normal pancreatic function after the decay. Here, the important investigations in ketosis-prone diabetes are C-peptide levels may vary after the decay episode. It reflects that there is some chances of beta cell recovery. Autoantibodies are negative for GAD, IA2 and ZNT8. HbA1c typically is greater than 9. At presentation indicates marked hyperglycemia. Insulin resistance is usually pronounced. So here, I would like to summarize by showing this table where differences between MRDM and FCPD and KPD. BMI is low in MRDM. Ketosis is always absent. Insulin requirement is high in malnutrition-related diabetes mellitus. Pancreatic calcifications are absent. Autoantibodies are absent. Exocrine dysfunction present and severe. And malabsorption also is severe. FCPD, where there is late adolescence, adulthood, and BMI also is normal or low. Ketosis is absent. Insulin requirement is high, lifelong. Pancreatic calcifications present, very important. Autoantibodies are absent. Exocrine dysfunction present, mild to moderate. Malabsorption syndrome is moderate. In ketosis-prone diabetes, patients present at the adolescence to adult group. Normal or high BMI, ketosis is almost always present. Insulin requirement is variable. It can be combined with OHA. That is the next. The pancreatic calcifications are absent. Autoantibodies are absent. Exocrine dysfunction is absent, and malabsorption is absent. So, what are the complications of type 5 diabetes? Can be divided into first the metabolic, where there's chronic hyperglycemia. Hypoglycemia is very, very common, especially in malnutrition-related diabetes mellitus, where there's poor glycogen stores and limited glucagon hormone response. Electrolyte imbalances, hypokalemia, hyponatremia, and hypomagnesemia due to chronic diarrhea and poor nutrition. Microvascular complications, where there's diabetic retinopathy, especially higher in fibrocalculous pancreatic diabetes due to long-standing hyperglycemia. Diabetic nephropathy, severe and malnutrition related diabetes mellitus, and FCPD. Early proteinuria, reduced GFR. Diabetic neuropathy, peripheral and autonomic neuropathy worsened by vitamin B12 deficiency. Macrovascular complications, where there is a coronary artery disease, which can lead to a myocardial infarction as well, especially in poor glycemic control. It is aggravated in poor nutrition. Peripheral artery disease contributes to non-healing foot ulcers. Other complications such as chronic pancreatitis, progressive exocrine and endocrine failure. Pancreatic cancer risk also is high in fibrocalculus pancreatic diabetes patients. So, very common diagnostic challenges, very commonly misclassified as type 1 DM, and it leads to unnecessary insulin misuse. There'll be high doses of insulin prescribed. Under recognition due to low awareness about type 5 diabetes outside the endemic regions. It very commonly overlaps with FCPD, even in the non-diabetic stage. And there is actually very limited access to special tests like the C-peptides, the autoantibodies, and the pancreatic imaging in low and resource-limited settings. Additional diagnostic challenges in type 5 diabetes. There is always, as I said, clinical overlap between the MRDM, FCPD, and KPD. Some of them share features with type 1 and type 2. This causes a lot of ambiguity before starting treatment. So it has to be very clearly differentiated with, from type 1 diabetes, very important. So unlike type 1, so type 5 diabetes don't have autoimmune markers. It can present in the youth and with high glucose levels. Type 1 often presents with diabetic ketoacidosis and requires insulin promptly. Type 5 often presents without ketosis and paradoxically does not improve only with insulin. They may need OHA as well in the future. Type 2 diabetes patients have a lot of insulin resistance, but in type 5 diabetes, there is undernourishment and there is increased insulin sensitivity. So that is one main differentiating factor from type 2. LADA, that is the latent autoimmune diabetes in adults, that is an adult onset autoimmune diabetes with slow progression to the insulin dependence. Type 5, and they have the autoantibodies present, whereas in type 5 diabetes patients, the autoantibodies are absent and they typically present at a younger age. And maturity onset diabetes of the young, also known as monogenic diabetes, often involves germline gene mutations with the strong family history of at least 3 generations and often kidney anomalies. But however, type 5 is due to malnutrition. They do not have any genetic predisposition, very less chances of genetic predisposition in type 5 diabetes. We would attribute it more to malnutrition. As I said, there's clinical uncertainty where there's a clinical overlap of the diagnosis. High economic burden because insulin costs are high. So cost of managing the insulin-dependent cases, especially FCPD and severe MRDM, is very difficult in resource-limited settings. And of course, there's a lack of standardized criteria. Apart from the IDF, no other organization has still accepted the type 5 diabetes. And there's a need for biomarker-based classification, which would improve the precision and reduce misdiagnosis. Precision medicine may play a very big role in the future for diagnosing type 5 diabetes mellitus. So take-home message, definitely the therapeutic approach. There's low-dose basal insulin combined with metformin, all-sulfonylurea, effective, affordable in FCPD and insulin-dependent MRDM patients, improves glycemic control and patient compliance in resource-limited settings, early detection, especially screening of malnourished individuals, recurrent pancreatitis cases, and unexplained ketoacidosis. So affordable insulin supply is very crucial, especially for FCPD and severe MRDM patients. We should conduct stronger nutrition programs addressing undernutrition, reduce dietary exposure to cassava to prevent FCPD, high protein diet and adequate calorie intake to reverse malnutrition, immunization, especially to prevent infections, and encourage moderate physical exercise. Research should be directed towards standardizing the criteria for diagnosing, biomarker-based classification. And as I said, there should be a special focus on precision medicine to cater to the metabolic diversity in tropical diabetes. Yeah, these were my references. I thank Dr. Pratibha Nadik for this wonderful opportunity. Thank you, man.
Thank you, Siddharth. That was a very lucid and comprehensive presentation. and you gave us a clear picture about type 5. And I think it is emerging. There are, as you mentioned, a lot of ambiguities, and diagnosis may not be easy. And since it is, which of the three is more predominant, malnutrition associated, or how is it?
So pediatricians would see more of malnutrition-related diabetes. Physicians, we see more of fibrocalculus pancreatic diabetes. It is a nightmare for us, because even small changes in insulin, as I mentioned earlier, small changes in insulin and the sugar just spike. So we have to, and if you increase the insulin, also seeing that spike, there's a higher chance of hypoglycemia.
Hypoglycemia.
It is actually an absolute nightmare sometimes to treat.
Okay. So you diagnose based on absence of those autoimmune markers.
That is one. And imaging, CECT,
Imaging.
very, very common. And
okay. Have you seen in your clinical practice? Are you in the
Yes.
process of?
yes, ma'am. Lot at Kasturba Hospital, Manipal, and here also Nano Hospital. Very common.
Okay.
And it not necessarily patient need not be an alcoholic. No. Very common where gallstones induce a lot of pancreatitis, and patients land up and with uncontrolled sugars, and patients land up in fibrocalculus pancreatic diabetes.
Okay.
And it is present very commonly with severe abdominal pain.
Severe abdominal pain.
So yes.
Okay. In the rural, lower socioeconomic categories, also we see a lot of malnutrition, because having done some work on tuberculosis, we found that many of them, and TB and of course diabetes, are always interrelated. So will nutritional supplementation reverse this insulinopenia and all?
Yeah, ma'am. If when detected early, malnutrition-related diabetes mellitus is very, very treatable.
Treatable. No, reverse. Reversible.
Reverse, the protein intake has to be, of course,
Increased. Okay.
Definitely.
But there are no such, there's no data on reversibility?
No. It's very
Dietary
less.
supplementation,
Yes.
and maybe because it's an upcoming area. Thank
Correct.
you. You have given very
The
clear.
toughest type to treat is the fibrocalculus pancreatic diabetes.
Okay, toughest one to treat.
Yes.
Okay. Any questions from the audience? Okay.
Yes, ma'am. Good evening, all.
please. Yeah.
Am I audible?
Yes, please. Vaishali, please go ahead.
Yeah, ma'am. Actually, I'm belonging to the pharma profession. I'm PhD scholar at Pune University. So
Please.
I'm using some polyherbal combination for diabetes mellitus. So what do you think, sir? Is it worth to use the polyherbal combination for this metabolic type of disorders? What do you think?
I have no data on that, to be frank with you. I will definitely look it up. So I have not heard of polyherbal formulations.
Dr. Vaish, yeah, if I could add, Dr. Vaishali, I have worked on some herbal formulations, not for diabetes though, but you need, if you establish through randomized controlled trials, and if you have enough data on the safety, it is worth trying. Why not? But we have seen as add-on therapy, as a combination, add-on to metformin, not responding or that way. But you need to have proper trials to prove the efficacy and safety. Then definitely I think you could. This is as a pharmacologist, not as a diabetologist. But if you do that, then the diabetologist will be convinced about the efficacy, and then it goes through different this one. You need to prove it. You need to show evidence.
Yes,
And
ma'am. Actually, I'm doing all this.
Yes, compatibility with the ongoing medications, if you want to add on. That also is required. Yes. Any
Okay,
other?
ma'am.
Yes.
Thank you so much. Thanks,
Thank
sir.
you. There's one question. How is, okay, this is Cyrus for, how is basal insulin? Cyrus, you can unmute and ask. I think if Dr. Shambo is there, this is for him, I think, no? Basal insulin. Okay. Any questions for Dr. Siddharth's topic?
Yes, ma'am. The basal
Yes.
insulin. So in clinical practice, how is it fixed? And is it based on sliding scale? And how do you fix a regular insulin to basal insulin?
No. So when patients present in the emergency, in the acute this thing, if the sugars are below 350, then we would go for the 3 times short acting, the regular insulin, and 1 time at 10:30. So we space it out. 8 a.m., 2 p.m. and 8 p.m. would be the regular insulin before the meal. 10:30 p.m. would be the basal insulin. That's how we this thing, because a lot of doctors just put only the regular insulin, but by the time it reaches midnight, there will be a lot of hyperglycemia. So that's the logic behind adding basal insulin at around 10:30 p.m. And of course, as I said, the regular insulin, you can use the sliding scale. Normally, basal insulin, we start at about at least 8 units or 10 units. We always start with a small dose so that there's no hypoglycemia in the morning. So we can use both sliding scale as well as going by the, we can try to put a regular conventional dose, and then we can keep monitoring and up titrating or down titrating.
Thank you,
Any
sir.
other questions? Any other questions? Okay. If no questions, thank you, everyone. Thanks, Dr. Siddharth, for being here with us, sparing your time. And thank you, audience, for being here. Some of you have left. I know it is Sunday, so difficult to, devote so much time. But however, they have been with us, and all the 4 speakers have been very good, given us what we actually intended our audience to know. I hope all of you have become wiser than what we were, because as I said, yes, Dr. Prabhakar is clapping, so I'm sure all the speakers were really, really good. And as I had mentioned, see, every disease is evolving, and with time, there will be, thank you, Dr. Sharma, Dr. Raj Prasad. So what happens is with the time, everything changes, and we need to definitely update on the same factors, on the same things which we discussed 10 years back will have a different meaning today. And with their great, rich clinical experience, we will definitely, we should be constantly updating ourselves. So this gave an opportunity, and thank you for all of you for being with us. Thank you, Dr. Siddharth, Dr. Shambo, Samrat, Dr. Aravinda, and also Dr. Jyotirmoy Paul, for though he was not there, he was not able to be here, he still made it a point to record and send it. And I'm sure all of you have enjoyed this. And we would definitely share the recording with all of you participants, because it is very valuable. With the permission from speakers, I'm sure they will permit us. So we will share the recording. And if any doubts or any other clarifications are required, you may please write to us. We will get them clarified through the speakers, or we'll connect you to the speakers directly. Thank you, one and all. Enjoy your remaining Sunday. You can, one more question has come. Other than dose insufficiency, are there any other factors for Siddharth, if you can answer?
Yeah. Yes, ma'am.
Other than dose insufficiency, any other factors for insulin therapy failures?
Yeah, ma'am, if patient is having an erratic appetite, ma'am, if they're, if one day if they're eating very well, one day if they're not eating at all, it makes it very tough for us, because chances of hypoglycemia are more.
Yes.
And there's also a fear apprehension where they think that if we write, suppose we write 12 units 3 times a day, they'll say we'll take 8 units and see, and not land up in low sugar. But the reality is they'll still land up with high sugar. Yes. A lot of fear and apprehension and this thing. Poor intake and infections, coexisting infections. Also, sometimes we have to combine insulin with OHA. We cannot depend just on insulin. Renal failure, again, affects a lot. So, because in renal failure, we're almost totally dependent on insulin. So, if we manage infections, and if the patient is having meals correctly on time, regular meals, and not erratic appetite, then insulin therapy is less likely to fail.
Less likely. So with that, we wind up. Thank you, everyone. Thank you very much. All right. Have a great Sunday, remaining part of the Sunday. Enjoy.
Thanks. Thank you.
Bye.
Thank you all.
Thank you. Thanks.